Hello everyone, I am Sanchika. I am from ECHO. A very warm welcome to everyone on this webinar series on the Sipher ECHO webinar on good and replicable and innovative practices of tobacco control in India. Today we have our chief guest, Dr. A.M. Kadri, who is the president of Indian Association of Preventive and Social Medicine. And our guest speaker for the day is Dr. Rakesh Gupta, who is the president in Rajasthan Cancer Foundation. Sir will be talking about setting up a tobacco cessation center in a private sector hospital. Now I would request Mr. Arun Verma, Director of Finance and Operations, for the welcome address.
Thank you, Dr. Sanchika. Good afternoon, ladies and gentlemen. I am Arun Verma, Director of Operations and Finance from Team Sipher. I am extremely delighted to welcome you all to our event, setting up a tobacco cessation center in a private hospital or being organized by the Sipher and the Resource Center for Tobacco Control, PGMAR. It is my great honor and privilege to welcome our chief guest, Dr. A.M. Kadri, who is the president of Indian Association of Preventive and Social Medicine, known as IAPSM. We are extremely grateful and honored that A.M. Kadri has accepted our invitation to grace the occasion with his presence and sharing his valuable insight and experience with us. I am also delighted to welcome our expert of the event, who needs no introduction, Dr. Rakesh Gupta, President, Rajasthan Cancer Foundation. He is going to share with us his valuable experience and inputs on the topic, which is highly important and relevant in the current scenario. As we all know that Dr. Rakesh Gupta has made immense contribution in the field of tobacco control and cessation and the issues associated. His presentation on today's topic will provide us a great opportunity to learn from the networking with and collaborate with experts and peers in this field. I also welcome Dr. Rakesh Gupta, President Sipher, Dr. Sonu Goyal, Professor, Department of Medicine, School of Public Health, PJMR, Dr. Sanchika Gupta, Manager ECHO, and Mr. Rajiv Chaudhary, who is a Program Coordinator, Resource Center for Tobacco Control, PJMR, all the esteemed participants and public health students. Once again, on behalf of Sipher and SC, I would like to extend a heartful welcome to Dr. A.M. Kadri and Dr. Rakesh Gupta for being present with us today. Thank you so much. Over to Dr. Sanchika.
Thank you, sir. Now I would request, has Rajiv ji has joined? Sir?
Yeah.
I would request Dr. Rakesh for discussion on the objective of the webinar. I think he's frozen. I would request Arun sir to take on this.
Yeah, thank you so much, Dr. Sanchika. Objective of the webinar, because Rajiv Chaudhary was from RCTC to us to present it anyway, because probably he has not been able to join today because of this, maybe this geo internet problem. As we know, the Resource Center for Tobacco Control under the Department of Community Medicine and School of Public Health, PJMR Chandigarh, organized national conclave on the best practices under National Tobacco Control Program in India, with an aim.
The Resource Center for
Dr. Sahab, आगे हो? Dr. Rakesh?
You can continue. Arun, you can continue, please.
Okay,
you can continue.
Yeah, PJMR Chandigarh organized a national conclave.
You can continue, please.
Okay. Organized a national conclave on the best practices under National Tobacco Control Program in India, with an aim to complete various initiatives undertaken by these states and document it at national and subnational level with respect to empower and NTPC for effective tobacco nicotine control. Practices in tobacco nicotine control from various states of the country have been identified. 25 practices have been identified as best practices in terms of its outcome to strengthen tobacco control in the specific region or a community. The presentations by the expert will help in increasing awareness and facilities across learning among stakeholders for strengthening the National Tobacco Control Program in the country and sensitize the stakeholders on the best practice for its replication in other states. Today's topic and speaker are presentation on setting up a tobacco cessation center in the private sector hospital by Dr. Rakesh Gupta, who is the president of the Cancer Foundation, Jaipur, Rajasthan. Over to Dr. Sanchika.
Thank you, sir. Now I would request Dr. Rakesh sir to introduce our guest for the day.
So, good afternoon all, and this is my proud privilege to introduce Professor Dr. A.M. Kadri. He is Preventive and Social Medicine. He is an Executive Director of the State Health System Resource Center, Health and Family Welfare Department, Gujarat. He was earlier Secretary General IAPSM in the year 2016 to 22. And he has more than 25 years of experience of teaching, training, and research in public health and community medicine. He is a former professor and head, Community Medicine Department, PDU, Government Medical College, Rajkot, and is past secretary IAPSM Gujarat chapter from the year 2011 to 16. He has worked as Joint Director, Gujarat State AIDS Control Society from the year 2005 to 10. He is editor-in-chief, IAPSM's textbook of community medicine, which has been a standard textbook for community medicine students. So technical lead of SRESTHA-Gujarat, a 5-year, $500 million World Bank assisted program of government of Gujarat. So we welcome you, Dr. Kadri. So I will request you to give your opening remarks regarding this presentation. Thank you.
Thank you very much for your kind words and introduction. At the outset, I am humbled for inviting to be a chief guest and give my opening remark on such an important public health issue. Before starting, I would like to acknowledge Dr. Rakesh Gupta, President and the Director of the Strategic Institute for Public Health Education and Research, Chandigarh, for inviting me. Also, our today's eminent expert who is going to present, another Dr. Rakesh Gupta, from President of Rajasthan Cancer Foundation. My dear friend, Dr. Professor Sonu Goyal, Dr. Arun Gupta, Rajiv Chaudhary from the RCTC Chandigarh, Sanchika Gupta from the ECO, other eminent personalities, and the dear friends and colleagues. I think when I was going through the topic of today's this webinar, it was very startling. Two important things which was, I think, which has, I would be saying that had attracted me a lot. One thing is that definitely it is talking about a webinar where it is having a series of the sustainable and innovative practices in the tobacco control in India. I think lots of good things are happening, but many times we fail to capture it and put it into document it and disseminate it. So I think that definitely this webinar is a very good approach strategy for capturing this good thing and disseminating good replicable innovative practices, that GRIP practices, what we are saying. That it is a really good initiative, and I congratulate for the team, ECO, and the all associated partner organizations. Today's topic is very pertinent. In fact, I must admit that for the first time, in fact, I come across for tobacco and the association or the in the connection with the private sector. In fact, for various public health programs, we have all various strategies, and we are working for associating or collaborating with the private sectors. For it may be the maternal health, it may be tuberculosis, it may be the immunization, or even the for IHIP or under the disease control program, other disease control program. But I have never heard about that we are trying to reach out with the private sectors and the trying to rope in them for this tobacco system. Then I thought about deeply about this thing, whether it is relevant and useful or not. Then immediately I think it is strike into mind. I think that is the why we have as a public health act many times the practice. We miss this important area which can make a huge impact so far I think we haven't kept this thing, and we haven't utilized the or collaborate with the private sector. In fact, one immediate example which has come into the mind when we are setting up the suggestion center, that is the very well established initiative that is the baby friendly hospital initiative. I try to link it, associated with it, how it can be similar initiative what we have been practicing for the promoting the healthy baby or the and promoting the fostering the various healthy baby practices in the mother and improving the health of the children, infant and the newborn. So definitely similar kind of the initiative can be we can take for the tobacco seizures. So when I was thinking about that, definitely it seems that definitely a hospital which is conventionally working on the patients and on the sick people, they are many times missing to address the underlying risk factors of the important health problem, that is in our case is the tobacco chewing or tobacco smoking habits. So definitely if we have to provide the comprehensive healthcare in the hospital setting, we should have such types of the uh, setup which can provide not only just cure the carry out the surgery of the cancer and give the chemotherapy or radiotherapy of the cancer or drugs and for the other problems related with the topic. On the we should definitely, along with that, we should take an opportunity to identify early and try to modify the behavior of the change the behavior of the persons who are at the risk of this cancer or problem health problem related with the tobacco, and we should definitely make an attempt to create an opportunities where we can definitely push the or offer the patient to a person who are healthy tobacco cessation behavior. So that is definitely a thing. But when I started having the deeper thing, then I thought about private sector. It doesn't mean we should not restrict to the private hospitals only, private doctors only. Private sector is a huge sector, and definitely we should look beyond the hospital setting as well. So when we talk about the cessation, setting up the centers for tobacco cessation, we should also leverage various other institutes as well. Immediately, what has come into my mind is the educational institute, because many of these habits are inculcated during the early age, and many times they are the student age or the during the college age period. So definitely, we should not restrict it to the up to the setting up to the hospital only, but definitely we should focus on the collaborate with the educational institute as well. Then when I started further thinking, then it again struck me that we should also expand the our initiative to the work for to the workplace, and in it may be the industries or the offices also we should think about. Third thing, then it has come into my mind that who will be the beneficiary. It is not the only person who is the chewing or habitual of the using the tobacco. Definitely, insurance agency is the greatest beneficiary. If you are talking about the people, then if the people are adopting healthy behavior, then lesser number of the claims should be there. So definitely, insurance agencies should be roped in, and they should try to see that have this such types of tobacco cessation centers should be more and more. They should be involved into the health education behavior, initiatives and the tobacco cessation, promoting the tobacco cessation centers in various institutes, etc. Besides that, definitely community at a large, various community organizations are there, and these community organizations should be profile for the setting up of these types of the tobacco habits, because many times persons when they are reaching to the hospital, they are many times quite late. Habits is already I think deep rooted, and disease has already or the pathology is already started. So if we have to it deep it in the birth an early stage, so definitely at the community level, and we should rope in the, various community organizations, which are again the part of the private sector we can think about. And that's why, in fact, I thought about this really a very potential strategy and very pertinent topic, because when we talk about the Empower, that is the FCTC's framework, it is largely where government has to do, public sector has to do. But when it comes to the private sector, so like Empower, I think I will end with my another one sentence, that when we are focusing on the setting up of the tobacco cessation center in various private sectors or private institutes, we should have the approach of the 5 A's. 5 A's means that these centers should have the approach of ask, advise, assess, assist, and arrange the support system. So with this 5 A's, I will stop my remarks, and again congratulating the entire organizing institute, this organizing both institutions for taking up this important topic and providing me an opportunity to share my views. So thank you very much. Looking forward to be associated for such good ideas of noble work. Thank you very much.
Thank you, sir. Now, I would request Dr. Rakesh Gupta, who is the founder of and president of Rajasthan Cancer Foundation, for his didactic presentation on the topic. Sir, you are muted. Please unmute yourself.
What I am seeing on my desktop is your photo, and my presentation I can't open right now. Yeah. All right. Let me go back to a few slides. I'm unable to move the slides. Sharing first and then go back again.
Yes.
Yeah.
Able to do? Are you able to connect?
Yes, I can do now. Okay. So my sincerest thanks and gratitude for RCTC and also for the inclusion of this in the group volume 1. Am I heard very clearly? Dr.
Yes.
Sanchika?
You are
Yes, sir.
audible.
Yes, sir.
Okay. I'm very grateful to our chief guest of this session today, Professor Dr. Kadri Saab, who has been to accept our invitation and give his insights, which are valuable. He has a vast experience, and I consider he is also presently in this position where we can have definitely much more progress, expected progress in this particular area, because tobacco cessation is a low-hanging fruit actually, but yes, it requires a lot of person or just analysts or adding and establishing the ecosystem in their organizations. I wish to convey my interest to the management, both tertiary care hospitals and patients whom I have treated at their TCCs, who gave me an opportunity to get into the insights of how the TCCs can be established in a private health sector. And lastly, but significantly, to all the participants of this webinar, because we were initially worried that this topic may not be of interest to, but I think we have a huge attendance, and I think that is very, very inspiring. Going to the agenda, I wish to talk about introduction of the subject with little brief on global and national scenarios of the TCCs. I will talk about the engagement of the management of a health facility to establish a tobacco cessation clinic and run it through a systems approach: screen, treat, and follow. These are 3 elements of this approach. Then I'll talk about the conduct of ACC, TCCs through a framework for the treatment, follow-up, and the report. And lastly, I'll describe about the specific measures which should be undertaken by the stakeholders in tobacco control for further upscaling of the TCC services. Going to the global scenario, if we see the coverage of the population and in tobacco cessation, specifically between 2007 and 2018, we find that cessation programs have significantly increased after the pack warnings under Empower by 21%, which is the second highest increase we see under Empower. But also when we see it little more closely between 2016 and 2018, we find that the
Dr.
cessation
Rakesh Gupta,
programs
there is an
which have
echo.
coverage.
There is an echo with your voice. I don't know why. Can you check, please?
I can't really, actually, I'm not a highly technical person, but is it still there?
Oh.
Is it still there?
It is there. Yeah, it is there.
Dr. Rakesh, if you are signed up for two equipments, then echo might be there. Maybe a mobile and computer both.
Okay.
You'll have to switch out one of them.
No, mobile. I'm not using computer at all. I'll put the phone off. So that
will be better. Thank you.
Dr. Sanchika, can you help out, please? Dr. Sanchika?
सर मोबाइल आप थोड़ा दूर रखते हैं तो बेटर हो सकता है. सर आप हमें सुन सकते हैं? आपका वीडियो फ्रीज हो गया है. He's
Dr.
Sir, sir, you are muted. Please unmute yourself and you can share your presentation again.
Audible?
Yes, sir. आप
ठीक है.
आज कुछ ना इंटरनेट के है सी इशू.
Okay, is it better now?
Everyone
Yes,
is
sir. अब
having
ठीक है, sir. अब
Okay.
ठीक है, sir. आप
yeah.
You want me to repeat the previous slide?
नहीं सर वो ठीक था. आप ये वाली से आप शुरू करें.
Right. So going back to this closer look on the tobacco cessation delivery world over through the Empower. Hello.
हाँ sir, please
Okay,
please continue, sir.
Okay, so what we see is that there is a little bit of regression, although it's -1% between the years 2016, 2018. But this is little old data. We will have to catch up with the newer data. But what we are also seeing is that between 2014 to 2020, we have rather sort of steadied only. We have not improved on tobacco cessation delivery globally. So that's one aspect that we need to take into consideration. We also need to think in terms of our national scenario. The Tobacco Cessation Clinics Project of India was started by the Ministry and the WHO India way back in 2001. I was one of the PIs of another 13 institutes which had established tobacco cessation clinics. And these are all the centers of excellence, but in psychiatry, cancer, etc., or the respiratory disease. However, that project did not really help so much the country as this National Tobacco Control Program, one of the arms of which is to establish tobacco cessation clinics at the district level in the country, throughout the country. Now, we need to also look into the data from the GATS 1 to GATS 2 with a gap of 7 years. What we found that in those 7 years between 2009-10 to 2016-17, the number of former users was still less than 2% at the population level. And the ratio for the current former smokers and former smokeless tobacco users was 16.8% and 5.8%. So obviously not many people have been quitting tobacco until then. Although the awareness has raised on the harms of tobacco, but the majority of the users are still unaware of the benefits of quitting because this is not talked about. The mass communication efforts of the ministry are also missing. So also the IEC, state IEC department, they are still not engaged in promoting the quitting part particularly. Although there are various steps which some of the states have taken, particularly I know of Rajasthan, where even in the A&M diaries, they have directed the A&Ms to find out the number of tobacco users in the families which they are attending to and bring it to the notice of the next person in charge. Also, one more thing which is patient related or tobacco user related is that although there is a higher intent to quit by the young, the urban and the educated people, but overall intent to quit tobacco in next 12 months is less than 20%. So about 80% people still don't want to quit tobacco. These are current users or those who do not want to quit tobacco or those who don't know what to do. So we still have a large burden of people who are currently using tobacco and who are unwilling to quit tobacco. Now, this is despite the fact that there are established benefits of quitting, which begins within 15 minutes of quitting itself. That means every tobacco user who is not using tobacco for next 15 minutes, the benefits start of quitting. And this can continue with the total abstinence. With the recovery, which is at the short term, we see that there is an improvement in the heart and lung functions. In the midterm, it comes to the reduction in the risk of the heart attacks, which reduces along with the risk of the stroke in next 5 to 15 years, and also the risk of cancers, which reduce by half in next 10 years, with further benefit of tobacco-related cancers and the NCDs. Their management becomes easier with lesser rate of complications and recurrences. So the benefits of quitting are well known to the people, and these come in very quickly. And that is why I tell people that you need to really think and promote quitting, because one has to remember that if people quit before the age of 30 years, a tobacco user will save the 6 to 10 years of premature average loss of life, as has been observed in one of the largest studies the world had in UK of some 34,500 doctors observed over a period of 50 years. This is also a big saving, as spending on tobacco products get eliminated immediately, and so also the user's potential spending of treatment of tobacco-related illnesses and the losses due to the premature loss of life and productivity. So the message is very clear that one needs to quit regardless of the age. That is possible if it is done. The benefits are immense. The message which should go therefore in promotion is that tobacco kills, quitting benefits. We need to sort of modify this message that we have been giving that tobacco kills. We need to add quitting benefits. And people have to make the right choice. And this should be the message for every user at each time and at every opportunity, wherever we can provide this message to the people who are currently using tobacco. To define tobacco cessation clinics, the tobacco cessation clinic is an office place in an OPD of a health facility that delivers tobacco cessation. It can use various terminologies as tobacco dependence treatment center, the nicotine de-addiction center, or tobacco treatment center, or in Hindi, Tobacco Upchar Kendra, whatever suits to the people. Now, when we look at the TCCs in India under NTCP and other health programs, the TCCs have been established in over 600 districts. Also, the tobacco cessation is delivered through the NCD clinics, RNTCP program, the AIDS program, and also in the camps conducted under the National Mental Health program. Tobacco cessation is now very much delivered through the national and 3 regional quit lines and M cessation program we have. And also it is done additionally through the psychiatry departments in the medical colleges and the national and apex government institutes. Also under the tobacco intervention initiative of the Indian Dental Association, which has about 1,200 people trained and who must be doing the tobacco cessation work. And also the TCCs are present in some private and corporate health facilities. Sorry about this. This is the operations organogram in tobacco cessation delivery, that at hospital level, there are about 12 stakeholders, right from the management to the patients, and this includes the medical director, the hospital administrator, the quality control person, the IT department, the marketing people. And on the delivery operation side, we have assistant medical superintendent, hospital reception, the resident doctors. And then we have the de-addiction department, if it is there, and honorary consultant who is providing the treatment to the patients, whether these are walk-ins, OPD or IPD patient. As such, in a TCC, this come down to 5 stakeholders, from management administrator to the healthcare professional, the nursing staff and the reception staff, the pharmacy in charge, and the patients and their cares. So this organogram should work with flexibility in every health facility. That is what I mean to convey through these 2 graphics. So let's look into what are the requisites to establish a tobacco cessation clinic. The first and the foremost requisite is, which is the most critical step in decision making, is the concurrence with the management. Without this, we naturally cannot establish a tobacco cessation clinic in a health facility. It also requires administrative support, inclusive of the NTCP state and district teams. In the government setup, it also means initiative or support from the collector and district magistrate, the CMHO, PMHO, and the in charge for the TCC. And in private sector, it applies to the owner, the MD, the medical and nursing in charges. The key is to have a leadership that is visible, stays engaged, and in a sustained manner. So we have 2 systems naturally at large, and I think in both the systems, we really need to work through the leadership first. This is very important, and the leadership should show the visibility and stay engaged. Then only the TCCs can be run successfully. The second requisite is the availability of the infrastructure, and this requires the size, a room of size which can help the people, enable the sitting of the doctor, the patient, and at least 2 or 3 attendants who come with the patient generally. The furniture fixture, therefore, the equipment, which includes the PC, the desktop, and a printer plus stationery, and some additional area for the OPD staff and waiting area. At the hospital reception area, we require the trained people who can work as part of the systems approach to help screen the patients who are using tobacco and guide them to the TCC. We also need to have within the hospital information staff the specific software, if we can develop this, to log for the questions on the current and former uses. This I consider is very helpful to screen the patients who are tobacco users, and their data retrieval and analysis can help us know as to how many tobacco users are attending a hospital. And incidentally, in my current hospital, the data matches with the prevalence of tobacco use, current tobacco use in Rajasthan itself. So I expect it may be the same for the other states also. Then we need to have the displays, visibility of the presence of TCC within the hospital is also very important. So also the availability of the information material, and naturally it is definitely related to the designing, the printing and distribution to the patients and also their carers, so that they have a know-how. Even if they are not tobacco users, they can disseminate the information to the tobacco users they know within their communities or within their families, who can come and take the assistance on site, and also assistance on site which can be provided by the medical social workers or their equivalent in the health facility. The fourth requisite is the patient and their caregivers themselves. Motivation of the patients is very important to quit tobacco. There are many people who know that they have to quit, but they do not defer quitting when they are coming to the hospital because of the primary element which they are suffering with. They don't want to have another consultation many a times. They also don't have time many a time. They don't have enough money to spend on quitting of tobacco, especially if they are coming to a private setup. So there are several patient-related issues. So motivation of patients to quit tobacco when they are in a health facility, I think is very important. This is the best opportunity for the patients, or we can provide that as an opportunity to the patients who are currently using tobacco. This information requires to be given in the form of information material which they can carry on with them and use it also in the future. The guidance and support to reach to the tobacco cessation clinic is also very important, because many times now with the multi-speciality, large, big hospitals, people coming from semi-urban areas or rural areas find it difficult even to locate TCC. So it's very important that they are given the guidance and support. And then also they need the advice on compliance of the treatment. Even if they have reached to TCC, the advice is also required for the compliance and treatment and the follow-ups, particularly the telephonic follow-ups. The patients and their caregivers should also have access to the waiting area, to the drugstore and the facilities, so that their experience becomes pleasant and comfortable while they are taking the treatment for quitting tobacco. This is considered by and large a habit and not an illness, and therefore it's very important that they are given enough and due considerations when they are within the health facility to help them quit tobacco. Lastly, but very importantly, and the most importantly, I will say, the healthcare workers who are working in a health facility, their motivation is very important. Also the training, so that they get trained in tobacco cessation delivery by themselves and by also referring the patients to the TCCs within the hospital, and also sharing of the outcomes one-to-one or collectively. There are 3 points which they should remember. One is that tobacco use is a disease and its user is a patient. Second is to treat every tobacco user at every clinical encounter every time. This is a dictum which should be set as a reminder in all doctors' rooms, OPD rooms particularly. And then people need to follow the systems approach of screening, treating, and follow-up. If the doctors or the nurses cannot deliver tobacco treatment directly, I think the best option is to engage the patients for the referrals. This I consider is the toughest barrier, because even within the hospital, when they know that there is a TCC, the referrals are difficult to come by. There are 3 elements which are required in cessation delivery, because I consider that it is not necessary that only a clinician runs a tobacco cessation clinic. It can be done by a counselor. It can be done by those who are even non-medics. If they have these 3 characteristics. One is competence, means they know the subject well. They also know its nuances. They can communicate very well on tobacco cessation and tobacco control by and large, and they have a commitment to help people to quit tobacco. It is eventually, the bottom line is that delivery of the service with the quality and for the endpoint, which is the tobacco-free life by the patients. If this is kept in mind, I think the tobacco cessation delivery can be done in an effective manner. The conduct of a TCC in a hospital. I have prepared this graphic with the setup that I have currently, where people can either walk in or they are the referrals. They come to the hospital reception, get registered here, then they are coming to the tobacco treatment clinic. Tobacco treatment clinic also receives patients from the IPDs to the referrals from the consultants. And then the patients are delivered treatment on the framework of the consultation, which is a 10-point agenda. And once they have taken the treatment, then they are informed on the follow-up that how the calls will be done, how what will be the details which will be asked to them, and we will also resolve the issues accordingly. And these telephonic calls are done on 3rd and 7th day of quitting, and then at the end of 1 month, 3rd month, 6 months, and 12 months. And if the patients desire to follow up in the clinic, or they come for the follow-up of their primary ailment, this can be much better, and this can be done otherwise specifically if somebody is willing to do that. I personally feel that telephonic follow-up is easy for the people, and they feel more comfortable, especially in reference to tobacco quitting. Some patients who come to the hospital, urinary creatinine test can be done for the biochemical confirmation of being a successful quitter. or for their failure to quit or relapse. Sometimes there is an element of patient deception, and this can be detected through the biochemical analysis. So this is how a TCC should be conducted in the hospital. There are about 8 determinants for successful quitting, but there are 2 which are most important. One is the current user's ability to stay quit from the initial date of quitting. And second is the regularity in our telephonic calls. The prompt responders stay quit. This is very important. The people who are responding to your calls, and at least the first 3 follow-up calls, which are done on 3rd day, 7th day, and at the 30th day. If the people are responding to your calls, that means they are already quitted successfully and they want more information or little more reward and reinforcement for them to stay quit. So these are 2 most important determinants for a successful quitting by the current users. The data can be kept in readiness. I use the dynamic Excel sheet, which I have been reviewing on daily basis. I have a cohort of some 1,000 patients, and I have followed them for over 5 years now. And if we look at this, the results of this cohort, we find that quit rate for over 5 years is 35%. The relapse rate is 19%. 31% patients failed to quit. 10% did not respond to the follow-up calls at some stage, and therefore they were categorized as non-responders. 4 patients died of comorbidity, and 1% patients were found ineligible. So out of 99% patient, I have a quit rate of 35% at the 5 years. With the other studies that I have compared, I consider this is one of the highest quit rates in the country. And but also we need to note that there is an increasing rate of relapse also in the patients, and therefore the follow-up calls become very important calls for these patients, or overall in tobacco cessation delivery, wherever we are having the TCCs, the follow-up calls are something which requires to be established, because this is one aspect which I found is lacking in my colleagues who are working in Rajasthan in the TCCs at the district level. Now, how the reporting should be done? It is based on the demographics, which gives us the data on monthly registration, the age and gender distribution, the type of tobacco use, the type of user, whether current user or former user, whether they are addicted to tobacco, are they using other addictive products or not, what are their associated elements, what pharmacotherapy is given to them, NRT and other cessation medications, what is the self-efficacy scoring after the counseling session, how they have been followed up, what have been the outcomes, the conclusions, and the recommendations for in-house improvement. So this reporting, I have been following a procedure electronically and also through the formal report as is given to the hospital administrator. We have an MD and then we have the health secretary trustee. So when they are given the report, I think this gives more information to them as to how the TCC is being conducted and what are the outcomes. It has been appreciated by the NABH people who have been coming to the hospital on a regular basis. Our hospital is NABH accredited hospital, but they have also been telling similarly, as Dr. Kadri Sahab has said, that currently, yes, people do not have awareness even within the health systems about establishing a tobacco cessation clinic within the private sector. I think that is where we have a huge challenge as to how we can establish it. And to this, I have some suggestions. One is for the health managers, that they need to establish systems approach within their hospital to screen all patients who are coming for tobacco use, treat those who are tobacco users, and follow these up. Now, this can happen, I consider it can happen only when we are coding the tobacco users through the ICD coding and also monitoring their outcomes through the hospital information system. And we also need to develop and sustain the health facility to be tobacco-free through a policy. Many hospitals still are not tobacco-free. There are many patients who are sitting within the premises and are using tobacco. I think that needs to stop, because until you give them the sense of and experience of a tobacco-free workplace, or a hospital, perhaps they will not understand the importance of quitting tobacco. The second stakeholder is the healthcare professionals. They need to empower through the trainings, through the online courses. We need to simultaneously train the nurses and other hospital staff, those who are working in reception, those who are working in the information system, the ancillary workers through the master trainers who can be within the doctors and nurses. And then they also should be acquainted with the use of systems approach for helping every patient quit tobacco at every clinical encounter. The third stakeholder, as I told, is the patient and the caregivers. We need to inform them that tobacco use is a disease and every tobacco user is a patient. I consider this is a norm that we need to establish within our communities. We need to empower them to demand treatment for quitting. Unless the tobacco user patients themselves will ask, I consider the healthcare professionals perhaps will stay indifferent or ignorant about the tobacco cessation delivery. So we need to orient them to the use of, also we need to orient them to the use of the National Quit Line and M Cessation program, because it has been found that those who are using both the TCCs as well as the quit lines or M cessation, their success rate doubles. So it's very important that the people are given multiple portals to stay quit for a longer period of time or permanently. The fourth stakeholder are the non-users. Considering that in India, nearly about 28.6% adults are using tobacco, that means these are 70% who are non-users of the entire population. We need to encourage them to participate in tobacco cessation delivery. Those who are in our communities, those who are in the civil societies, organizations, self-help groups, the corporate, those who are working under corporate social responsibility, and within the media, plus the social media, which has now has come into higher prominence. I think all these categories must be participating in promoting tobacco cessation delivery and motivating the current users to quit. So to sum up, I would say tobacco epidemic is a ticking time bomb. Global and national tobacco control and cessation efforts needs revision and a stronger thrust. The healthcare stakeholders, especially the managers, can contribute significantly and hugely. Quitting benefits regardless of the age or regardless otherwise also. Promote and support of TCCs and tobacco users to succeed in workplaces and communities is the need of the hour. I consider that the take-home messages, therefore, should be that TCCs can be conducted in any setups, can be established and conducted in any setups. You can modify it like this. Setting up of a TCC requires identification of all the stakeholders and collaboration with them. For successful sustenance and growth of TCCs, we need to acquire the requisites, which I have outlined, analyze the outcomes on a regular basis, and report these to the stakeholders, all the stakeholders, so that not only they know about what is happening in TCCs, but it also gives us an opportunity to self-analyze and introspect as to how we can further improve the quality of tobacco cessation delivery and also the numbers. And lastly, establishment and conduct of a TCC in a health setup are a win-win model for all concerned, the management, patients, as well as healthcare workers. I wish to give you here the example that I have experienced in my own hospital, where we had conducted a data analysis between the January to September of 2019. We had nearly 64,000 patients, because our hospital has about 1,200 to 1,500 patients coming to the hospital on a daily basis. And we found amongst these 25% patients were tobacco users. Even if they had paid the hospital for one consultation, which is 600 rupees, out of which 50% goes to the hospital, I think the hospital would have earned the revenue of nearly 3 crore rupees. I did bring it to the notice of our medical director. He said, if this is the case, you will be the busiest clinician in this hospital. But somehow, even then, he did not really work to strengthen the tobacco cessation service. So I think there is a lot which can be done. The people who are working in private sector, they should not feel that setting up a tobacco cessation clinic will be not helpful, will not be a financially gainful establishment for them. I think we need to convince them on the economics aspect also, so as to promote the establishment of TCCs within the private health sector, which I think has become now more relevant as more and more people are undertaking the health insurance, and there are government health insurance practices as well. I think the tobacco users, those who are not using tobacco, their premiums can be reduced for the payment on a yearly basis. That's one way the insurance companies should be empowered actually for helping the tobacco users quit tobacco and for their reimbursement. So I think I'll end here my talk, and if there are any more comments or questions, I'll welcome those. Thank you very much for your kind attention, and I'm so very grateful for getting this opportunity within a week's time. I hope it has not become sort of monologue, and there we have a good interaction on it. Thanks once again.
So thanks a
Thank
lot, Dr. Rakesh Gupta. As always, actually, it is an excellent presentation. And as you said, that 25% of the total patients in your hospital, they were tobacco users. And you can talk with experience in a cohort of 1,000. You could succeed in 35% of the cases. That is a very good success rate, actually, if we consider it worldwide even. And 19% relapse, that is, I think, common, because addiction to nicotine is very, very strong. So relapse is common. But as you said, that it is a disease and it has to be tackled as a disease. So that is good. And to sum up, you said the tobacco epidemic is a ticking time bomb, and global and national tobacco control cessation efforts, they need revision and stronger thrust. And it is good that you have emphasized that uh, not only the government hospitals but the private hospitals, they should all have TCCs, and they do gain from these TCCs.
Yeah.
It's not that it is they don't earn anything out of it. They definitely earn out, and you have already told your management also. So that is very good. So I'm sorry that we won't be able to take, in fact, any questions because of we are already running late. But I have shared, sir, I've shared your email ID in the chat box, so they can directly ask you if there are any queries. But I'll just acknowledge the presence of Dr. Ramprasad Vasre, Dr. Sahana, Dr. Dilip, Dr. Siddhi, Dr. Kalpana, Dr. Aruna. So they are with us. They are all stalwarts in tobacco control. So thank you, and all the participants, I must thank you. And before taking the concluding remarks from Dr. Kadri, I'll request all to please switch on your videos so that we can take your snapshot. So Dr. Kadri, so may I request you to please give your concluding remarks, please. Yes, Dr. Kadri, are you with us? Dr. Sanchika, can you please check if he's still with us?
Yes, sir, he's there.
Okay. So Dr. Kadri, can you give us the concluding remarks, please, on this presentation? Dr. Sanchika, are you taking the snapshot?
हाँ सर हो गया
Okay. So Dr. Kadri, maybe he's not able to listen to me. Dr. Rakesh Gupta, आप एक मिनट
He did mention that.
Am I audible otherwise?
Is called by the. You are audible.
Okay.
I think.
Okay.
mentioned to me in our initial interaction that working in the government setup, he may be called the additional chief
Okay.
secretary health. So he may have
maybe he
engaged
is
there.
left then.
We can take the comments from our colleagues maybe. And
So, Dr. Ramprasad, can you just give some concluding remarks on Dr. Rakesh Gupta's presentation, please?
Yeah, pleasure, sir. Thank you so much for the opportunity, sir. It's really been a very insightful session. I think on behalf of all the participating delegates and audience, I think everybody will agree with me that sir has given a very clear guideline and a map, in fact, as to how to go about setting up a tobacco cessation center at any health setup, whether it's a private hospital or as a part of a learning center or as a part of a social meeting place and things like that. But I think more so in relation to a dental college or a medical college or a nursing or a pharmacy or a physiotherapy college, I think the guideline which sir has suggested is very useful and very practical. In the initial stages itself, in the initial slides, sir mentioned very positively about the close coordination with the management as to how to actually convince the management and how to actually effectively implement a tobacco cessation setup and all the infrastructural issues which are going to play a critical role, and over which these incremental buildups of the softwares, of the networking in relation to screening, referral, and so on. So I think it's been a very step-by-step incremental map which sir has given to us, and very grateful to you, Rakesh sir, for all the guidelines. Thank you so much, sir. Thanks a lot.
Thanks for your comments, Dr. Ramprasad.
very
And
welcome.
Dr. Dilip, please. Dr. Dilip, will you like to comment?
I must start with saying that it's kudos to both the Rakesh Guptas, because one who organized nicely ECO and everybody Sipher and everything. And definitely the session was very informative. As I would say that it is a यज्ञ है कि ये tobacco cessation एक यज्ञ है जिसमें सबकी आहुति चाहिए, be it doctors, medicals, non-medicals, and everybody. As we all know that about 70 to 80% of the healthcare is being provided by the private sector. And so today's talk was very pertinent that involvement of private sectors is very important in tobacco cessation. I've been trying to rope in all my doctors into this. So a bit successful, not very much, but still. So, but I think with Dr. Rakesh Gupta coming up with a revenue model for them, this is the best part here too. So once we can chart out revenue model for the private sector also, we'll share it with them. So I think they'll be more and more interested about it. Once again, very nice talk. Thank you very much.
Thank you. So we can have very brief comments from Dr. Aruna, Dr. Sahana. Dr. Aruna and Dr. Sahana, please. So Dr. Siddhi, can you comment?
Yes, sir. I liked the way sir put a positive note on the benefits of quitting should be more propagated. Doctors, we mostly comment on the cancer part that we can prevent that. So this good part about health should be definitely put up. It was nice. Thank you.
So Dr. Kalpana, can you give us very brief comments? Dr. Kalpana. Maybe she has left then. So Dr. Sanchika, I think we can have a vote of thanks. So before concluding the session.
Thank you, everyone. I would request Arun sir to propose vote of thanks. Sir, you are muted. Please unmute yourself.
Muted. Arunji, muted हो आप? Yeah.
Okay. Once again, good afternoon, good evening to ladies and gentlemen. I feel privileged and honored to propose this vote of thanks on behalf of the organizer, which is Sipher, RCTC, PJMR, and ECO India. Our special thanks to Dr. A.M. Kadri for accepting our invitation to be being with us on this important event on which he himself has a lot of knowledge and experience. He's mentioned about looking beyond hospitals for setting up these TCs in the education institution, workplaces, industrial premises is a good idea to be considered and adopted. We convey our hearty thanks to Dr. Rakesh Gupta for a wonderful and a very informative presentation. His sharing of knowledge on topic will certainly help participants to take home very useful knowledge and idea on the Tobacco Control and Tobacco Cessation Center. I thank Dr. Rakesh Gupta, President Sipher, and Dr. Santokba Gupta, Manager ECHO India, as well as all our eminent participants on this event. Thank you once again, and have a good day.
Thank you,
Thank
sir.
you.
So just last 1 minute, I would need less than a minute.
So, Dr.
I
Rakesh
want
Gupta, I'm sorry. Actually, the echo was at my end. It was not at your end, but it was at my end.
Yes,
So
yes.
I changed the mic, and then it was okay. I'm sorry.
No issues.
so just I wanted to take
But
a
I think
30
recording
seconds.
will be all right. Dr. Sanchika? The recording would be okay. Okay.
Ha, sir.
Thank
Ha,
you.
sir.
Mhm.
I just wanted to take 30 seconds of the participants and wanted to inform about our next session, which is on 27th of September, that is Wednesday, same time, 4 p.m. onwards. The topic will be number 13, that is building capacity of NTCP officials for advancing tobacco control in India. And our subject matter expert will be Mr. Mukesh Sinha. So please do join us on 27th of September. We will see you again. Namaste.
Namaskar.
Thank you. Thank you all.
Thank you all.
Thank you, Doctor. Thank you so much.